Good day, my dear postgraduate students. The class for the day is the complications of heart-lung transplantation as well as cardiac surgery. So this is a topic from the recent advance thanks to Burke. Always landmarks are essential. For example, in this particular topic, subheadings such as clonality, types of rejection, complications of support, as well as the side effects of drugs are all unknown to us in the general vocabulary. Hence, I would like to put your heart, mind, and soul in this class of mine. The prologue, which is the beginning. Always you find that there is a chain of events starting from the removal of an organ, maintaining the sterility of it, as well as the intricate mode of transplantation. On the right side, I am finding a picture of the heart and the pair of lungs. Strangely, it is any of these organs or part of the organ that is released and replaced, whereas the great vessels and the bronchial tree, etc., remain in position. What are the indications for a heart transplant? Thanks to this particular list from Medscape. So it can be a dilated cardiomyopathy or an isolated cardiomyopathy, which is ischemic. Congenital heart disease, for which all other modes of treatment have failed. A low ejection fraction, intractable angina, pulmonary vascular resistance of less than 2 Wood units. And the age of the patient has to be less than 65 years, and he has to be able to comply with the follow-up treatment. The modes of transplant can be heterotropic or orthotropic. Complications in the form of surgery. It can be bleeding from the suture lines, hyperacute rejection, infection, any form of psychiatric disturbances because of steroid therapy look very strange. Even by the surgery itself, there can be psychiatric disturbances. Cardiac rejection and allograft vascular disease, for which patient education is needed. In this diagram, thanks to New England Journal of Medicine, I am finding that there is a hyperplasia of the intima, that is shown. And what are the different laboratory studies? An important list that we should have in mind. I have compiled it and compressed it so much that it is easy for us to remember. You find that there can be any infection because of viral, fungal, or bacterial. So the virus is mainly the CMV, HIV, and EBV. Remember V. And also you find that certain other investigations such as the Pap stain as well as the Papa-Nicolau and the prostate-specific antigen are included. I do not know why. There is a complete panel of reactive antibody, the HLA typing, CBC, and the immune sustainability that are to be assessed. And this is a diagram of the HLA MHC complex, major histocompatibility complex, which by itself is a question we shall see at a later date. And in the heart, there can be the other studies which include imaging. Under that, you have got the arteriography, echocardiography, the chest X-ray, thoracic pathology, and bilateral mammogram also are included. Also, there is a cardiac and pulmonary evaluation for which the oxygen consumption and followed by the right and left heart catheterization and also monitoring the vascular resistance. Biopsy, here it is said that it is not usually performed, but there are some schools of thought which say about 4 biopsies are the most. 4, it is not core, can be performed. The heart transplant procedure, a wonderful picture, thanks to Mayo Foundation. I hope they forgive me for this diagram. So there is a donor heart, and you find that finally the patient's heart is being removed. So it is being placed in position. You find, as I told you, that the great vessels are still in position, and after the replacement surgery, the patient's deceased heart is removed, and finally the donor heart is in place. Lung transplant, again, there are certain qualifying conditions. You find that only one lobe from a donor, preferably a part lobe. Diseases such as cystic fibrosis, where two lungs are required, should be from different donors. COPD, pulmonary vascular disease, or hypertension, or an arterial hypertension. And finally, it all means extension of the life in an end stage pulmonary disease. And these are all the qualifying conditions thanks to Wikipedia. There are technical aspects in the transplant. See here, you find that there is an endoscopic tube. It reaches the site that it is intended to be for an endomyocardial biopsy. As I told you in the previous one, minimum of 4 is required. Endotracheal biopsies are for the lung. It can be under general anesthesia. For the lung, 4 to 18 biopsies are permitted. Obviously, very good technical handling should be there, no artifacts to worry the pathologist, and transplant autopsies should be ready as a backup. Again, the checklist. For anything, a list is required. So I would like you people to kindly go through this list. The details of the donor, the disease, the infection, any form of drug therapy, transplant, any of the ischemic details, and the blocks of the myocardium conduction system and the arteries. This incidentally is a diagram or a histology slide of toxoplasmosis, wherein the granularity is not very well brought out, but still the lesion is well demarcated thanks to Kidney International strangely in the heart. The infections, as I told you, it can be any of these things. It can be bacterial, it can be viral, it can be fungal or protozoal. And in the cytomegalovirus, you find that the virus can be found in the Buffy coat. Please add these words to your answer. The Buffy coat, in situ hybridization, look for alveolar damage, interstitial bronchiolitis or pneumonitis. And courtesy pathology outline, I am able to see this. Strangely, these can be commensals also, and that should be ruled out. So the problems to a pathologist, distinguishing between the infecting and the passenger CMV. In this case, I find that there are multiple foci of infection and it almost mimics a miliary tuberculosis to me. So differentiating an acute rejection from an infection, then the infecting and the passenger CMV, and distinguishing the different histological patterns, which are not usually seen in the transplanted patients. Toxoplasmosis in other source. So the donor-acquired infection, seronegative recipient without prophylaxis, and systemic involvement. These are all some areas where it has to be ruled out. And in a biopsy, intact cyst or a granuloma might be seen. Look at this one wherein I'm able to see the virus. So pneumocystis carinii, it can be an intact cystic space that can be diagnosed by means of a silver stain, or sometimes it can be having the shape of a boat-shaped inclusion. Here again, I'm finding multiple areas of consolidation that is seen, interstitial in nature. The types of rejection, a very important flow diagram that can be used. So there is a primary graft rejection or dysfunction, ischemic reperfusion injury is there, and then there is a mechanical ventilation, infections, immunological processes. When these are all there, there can be an acute rejection, which can be cellular or antibody rejection. These two words, if you people remember and write, it is good. And finally, you find that there can be a chronic loss. So there is a primary, an acute, and then the chronic loss. Because of the restrictive nature of it, the subsequent diseases, recurrence of the primary disease, then the anastomotic stricture that can develop, then there can be an A.R.A.T. and other causes. So long-term transplant surgeries, they will be requiring these things as a backup. One will be cellular therapy, anti-inflammatory, that I'll be showing you in a table. There has to be advanced preservation of the organ. Memory T cells will have to be activated, deactivated, and then there has to be an induction of the tolerance. The heart and the lung rejection. In this case, it is a lung. A rejection should be differentiated from an inflammatory pathology wherein there is a plethora of cells and it should not be diagnosed as an acute or chronic inflammation. However, in the background, I'm finding a vascular type of a necrosis. And these can be diagnosed by means of the flow cytometry. That is over here. Here, the routine one, it takes about 10 hours minimum. Here, within about 4 hours, it could be diagnosed. This is an important table wherein there is an antibody-mediated rejection that can show both histological and immunopathological studies. So it is negative initially, and then you find that there can be histopathological positivity but immunological negativity. And here it is histopathology negative and immunological findings are positive. Both of them are being positive. And finally, there are the various histological changes which include hemorrhage, fragmentation of the capillaries, inflammatory infiltrate, pyknosis of the endothelial cells, so on and so forth, thanks to ResearchGate, Christina Delicacy. We people should understand that these are all pioneers who have done amazing work in such field. Donor-specific antibodies, the pathophysiology. This has been mentioned earlier. I will not be going into it, thanks to the references quoted below. The complications of transplantation. This can be applied for any transplant as such. Please do remember, it can be divided into the early, the reperfusion, and the late complications. Early, remember, any type of a surgery can have an embolism, there can be a hypoxia, there can be a iatrogenic, definitely in this kind of sensitive surgeries. Pre-existing disease can be activated. I'll be showing you some. There can be renal tubular necrosis, pancreatitis, or adrenal necrosis, unimagined of. And reperfusion, following a cannulation, angioplasty, reperfusion injury due to the enzymes. Stunning, here I'm able to see the stunned myocardial fibers over here. So, and also the treatment can be intra-aortic ballooning pump. This is some kind of a myriad forming. So the late complication described as early as this, following surgical procedures similar to Dressler's syndrome. And it can result in the various forms of effusions and the cardiotomy syndrome because of the anti-heart antibodies. Graft versus host disease is quite rare in solid organs, thank God. And the immune complex is quite competent with the acquired or the associated lymphoid tissue. HLA typing is required. And this is one beautiful picture of a cancer patient who has been served with a double lung transplant, doing well. So there can be a pneumonia after the transplant, thanks to American Journal of Röntgen. So you find that there is a rejection, there can be an infection that can occur. And because of the immunosuppression that is given. And when there is a reduction of the immunosuppression, infection will be prevailing. So a deft balance will have to be maintained between these. So linkspring.com, a beautiful flow diagram. I would like you people to kindly draw this. What are all the various risk factors before transplantation, during and after transplantation? It can be within the recipient or in the donor. There can be technical issues or there can be surgical complications. I think this one flow diagram will encompass the entire class of mind. And finally, there can be early post-operative infections that can follow. The side effects of the drugs are also given over here that can range from nephrotoxicity to osteoporosis or even hirsutism. Very strange. So a plethora of drugs and the hypersensitivity, including bone marrow suppression, hepatotoxicity, and leukopenia. Neoplasias. Kaposi sarcoma we had already mentioned, and that is over here. You find it can be in a patchy stage, plaque stage, nodular stage, etc. And there's a typical histological picture, otherwise quite a harmless tumor. It was after AIDS that it came into force, and you find that the single diagnostic feature will be the extravasation of the RBCs. Immunosuppressive drugs such as cyclosporin can cause it. An Epstein-Barr virus can cause a lymphoma in the lymph node, tonsil, or even the GAT, wherein the chemotherapy is avoided. Lymphoproliferative disease, post-transplant lymphoproliferative disease. It can be a Hodgkin's or Hodgkin's-like lymphoma, plasmacytoid lymphoma, immunoblast resembling Hodgkin's lymphoma, and a Burkitt lymphoma. So here again, I do not know whether it is a Reed-Sternberg cell or a Reed-Sternberg light cell, thanks to pathology outlines, and there can be mutations in these genes. So reduce the immunosuppression, increase the acyclovir. And this is a kind of a steroid that is given over here, either topical or systemic, and then the chemotherapy has to be given. So this is a double-edged sword. Reduction of the immunosuppression, increase in the chemotherapy. Recurrence of the primary disease I had mentioned. After all, it is for the primary disease that a transplant is being done. It can be a giant cell myocarditis, a sarcoidosis, bronchial alveolar carcinoma, and amyloidosis. Amyloidosis. You find that it is pale with an increase in the organ, rather homogeneous. That is how it appears in the slide also. Pale eosinophilic homogeneous extracellular material. So the epilogue at the end of the class. The idea is not to live forever, but maybe to help another live a little longer. I hope I am doing this for the students. Thank you.